Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend, Colin. The world of technology and healthcare are ever-changing in new and novel ways, and that's why we love this stuff so much. So join us as we discuss the latest healthcare and health IT news meshed together in new ways, which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. On today's episode, we'll be discussing measuring satisfaction in healthcare. Today's episode is sponsored by Stericycle Communication Solutions. Learn more about their healthcare communication solutions at stericyclecommunications.com. And be sure to follow the show on Twitter at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 13 years of health IT blog content at healthcareittoday.com. So I wonder if we have a bunch of satisfied healthcare podcast listeners.
I certainly hope so, John. I certainly hope so.
Maybe we should measure the satisfaction of our podcast listeners by how many tweet after when they hear this.
that or maybe we can go old school and maybe send them a mailed survey.
I'm pretty sure those that are listening to the podcast are going to answer a mailed survey.
That's right. Well, that's actually a great segue into talking about our topic today, which is really just how healthcare measures satisfaction. So we've got 4 things that we're going to cover. First of all, we're going to talk about, are HCAHPS dead, or CAHPS, are they dead? Then we're going to move into talking about how should we actually measure patient experience. And then we're going to talk about something that should get a lot more attention, which is, of course, physician satisfaction. And then we're going to end off today by talking about an interesting statistic that we found online that came from the recent Cleveland Clinic Patient Experience Summit. So, John,
Great.
Let's talk about HCAHPS. Are they dead?
Are they dead? I would say no, they're not dead. If you ask any executive at a hospital or health system, they all know this number by heart. They know how it's changed. They know how it's evolved. So instead of saying that they're dead, I would just say that they're mature. So I think what's happened with HCAHPS is that they've essentially reached a stage of maturity where everyone is aware of it and everyone's working on it and everyone's done a lot of initiatives to try to improve those scores. And so it's become really mature. We saw this in the meaningful use regulations. And then as it pushed on to macro and MIPS, that there were a bunch of measures that everyone was meeting at basically 100%. And so it had just become so mature. It was one of the good things that they did in meaningful use. They said, hey, everyone's doing it, so why are we still measuring it? I'm not sure we're going to see that same thing with HCAHPS, but I think there's a real maturity in HCAHPS scores.
Yeah, I think, what's funny for me is I think in some parts of HCAHPS are dead. I think the mechanism in which the information is collected is definitely dead. Because doing it by phone and doing it by mail, which is actually dictated in the process, I think is a little antiquated. It doesn't take into account a lot of the new technologies and the new ways patients want to interact. So I think that part of it's dead, the mechanism of how to collect it. I agree with you. I think the measures themselves, I think it's important that we collect it. Some form of satisfaction metric is important. I think also, the fact that it's tied to reimbursement is definitely the reason why there's so much attention put on it. But I'm wondering, like you, maybe the measures are no longer valid. Maybe we need to refresh them or revisit them because, in a lot of cases, it does, it's 100% all the time, or it doesn't really capture the nuances of modern healthcare, right? Like whether or not you think your physician did a good job. I mean, is that really relevant in terms of the score? Should it be something else? Should it be related more to outcomes? Should it be more related to the wait times? All those things aren't factored in, or they keep trying to change it, but maybe not fast enough. So to me, I agree with you. I don't think it's quite dead, but I think the format of it, how it's collected, and it's certainly that part of it needs to be changed.
And I would take what you're saying one step further and ask the question, have they really improved patient satisfaction, or have they just learned to jump through the hoops better? Have they learned, I don't want to use the word game the system, but I'll use the word game the system to be able to change their HCAHPS scores, right? Like you said, if they're sending out letters, they realize that didn't work, so now they're doing it at discharge with an individual there, right? I mean, are they learning just how to game the system to improve their scores, or have they really changed the experiences so the scores improve?
Yeah, and I think, the one thing I will say about HCAPS, one of the big complaints is the fact that it's done so long after the visit or so long
Mm.
after the patient's been in the facility that, your memory, just human nature is you either remember all the bad or you remember all the good. You don't actually get an accurate remembering of what happened during the stay. And so, but at least it's consistent. I mean, every organization does this. So at least it was consistent across the board. No one was sort of cheating it. But I think a lot of people are now recognizing that it's only one metric of satisfaction, and it's done so long after the fact. So you're getting a really historical view. You really can't do much with the data. Like, it's not as if
Yeah,
you can go back and fix it, right?
no, definitely. And it also, I think, when you think about that, are we only hearing from the best and the worst? How do we create a method to be able to hear from the middle people who had a reasonable experience, but maybe not a perfect experience, maybe not an awful experience? So, I mean, that really kind of leads us to the next subject, like how should we measure patient experience? I mean, what are the measures that really matter? What's your take on that?
Well, I mean, I'll answer it in a slightly different way first. I think the how should it be measured? I totally believe that patient satisfaction should be measured in real time. I don't care what the metrics are necessarily right at the moment, but it's got to be done in real time, and for the sole reason of at least then you can recover. I mean, if you know
Mm,
someone's not having, is not having a good experience, or is experiencing something adversely, I mean, it's too cold in the room, food didn't arrive on time, or food arrived that I shouldn't be eating because I'm on a particular diet. I mean, those things should be done in real time so they can be addressed. And I think most hospitals and most healthcare organizations would agree that that kind of feedback, that kind of measurement is vital for them because they don't want to have patients that would have had subpar experiences, and only by measuring it in real time can you actually address it, right? So to me, it doesn't matter what metric it is, as long as it's done in real time, that to me is the biggest change that needs to happen with patient experience measures.
it reminds me of those little smiley faces. Have you ever seen those like
Yeah,
in the
yeah,
bathrooms at the airport or yeah, there's at certain restaurants they have them and you can either push smile, neutral, or angry, right? Usually it's those three. I think some of them may have five. It's such a simple thing, but it really, is powerful, I imagine. And to be honest, I don't know their system completely, but you can easily imagine if they're getting a lot of, happy faces, then they're like, life is good. We're all all is well. And if they start to get them some sad faces, then they say something's going on. And I think there would probably is an opportunity in healthcare to get this real time, 1 to 5 ranking, or even just a happy, neutral, or or sad face to kind of say where I'm at. And we'd probably discover a lot of interesting insights if they were just doing that all day, every day, because they have nothing else to do in bed. Of course, many are sick, so they probably can't even reach out and do that. But that's probably that would say something too, right? If they haven't checked in, if they or then they're either sleeping, which is a good thing, or there's some issue, and you maybe want to check on them. So maybe there's some interesting bedside stuff that you could do that kind of real time, ongoing, and if you train them the right way, I think the patients would really engage in something. Just it's a hyper simple action that they could do that what in healthcare and a hospital is simple, but that seems like something that could be.
Well, actually, it's funny you mentioned that because I wrote the piece when I went to the Barrel Institute patient experience conference earlier in the year. But that was one of the vendors was Smiley Answers, and one of the unexpected
Oh,
vendors
really?
I didn't think to see was exactly that, the thing you see in the airport washrooms where you click, the happy smiley face or the red face, right, depending on the feedback.
Uh-huh.
And they were there because they were seeing interest from patients and from the healthcare community for things like waiting rooms, for things like exam rooms and the cleanliness. Like you can just put any question you want and people can rate it.
Sure.
And yeah, I mean, to me, that's still a little bit after the fact because the fact that someone hits the angry button that there, I mean, it's doubtful someone's going to swing by right away. But at least it's more real time than waiting 2 weeks after, right?
Sure.
The visit to remember that. And so I think that has its place. I agree with you in the sense of, you got to try and keep it simple. I mean, feedback does not have to be complicated. It could be a 2 or 3 question a survey that's done in real time. It could be presented on the monitor inside the patient room. It could accompany the food that they're getting, right? Just to have a little rate card that they can fill out and just leave it there on the tray, and then somebody can, when they take it away, they can put those cards into some database. Or it can even be a phone number that you can just type in, press 1 for this, press 2 for that, right? That kind of feedback is very simple to implement, and I think it's a missed opportunity at most organizations.
Yeah, I think they call it growth hacking, right? This simple ways to really, hack growth, and I think these are the things we need to incorporate more of. I think sometimes we complicate things way too much in healthcare.
Agreed, and we're starting to see that a little bit, especially with online appointment booking, and all the follow-ups now happen through email. But right at the end, there's usually a, hey, do you want to take a quick survey? Or there's usually a couple of questions, or they're asked to answer right away, and that generates their real-time feedback. Because if they answer that, the appointment process was too complicated, sure enough, someone will call them right away and say, hey, can we just make sure, let's verify your appointment. People will do that. And to me, that's the real benefit of this kind of satisfaction measure, because you can recover, you can actually do something about it. And I think because of HCAHPS, they've been around for so long, I think people have matured to the point where they will now want to do it. I think before you had to force them, which is why HCAHPS came to be. There wasn't a focus at all on patient experience, but now because it's tied to reimbursement, and because now people realize it's tied to loyalty and keeping the patients in network, I think people are okay. Like, we don't need to be told we got to focus on it, but now we got to use the right tool to focus on it.
Yeah, and I think you bring up an interesting aspect, which is now most healthcare organizations have a digital channel to be able to reach out to their patients. Whereas, like you said, if we have to send a bunch of letters to them, or we have to, fax something, God forbid, to them, we're never going to hear back. But now more and more organizations have that digital channel to be able to reach out to the patients in a free or nearly free manner, so they could get that real-time feedback.
Right, and that's, we've talked about it in other podcasts too, but this is the whole thing where we can borrow from the consumer world, right? Like, we can take things from retailers, we can take things from the hospitality industry and go, hey, let's take some of those techniques and implement those in healthcare. I think it would be perfect.
Yep, I think it would be awesome.
All right. Well, hey, listen, if you're just tuning in, this is Healthcare IT Today's podcast and episode with John Lynn and Colin Hung. Thanks for tuning in today. Today's episode is brought to you by John.
Yeah, well, our sponsor for this episode is Stericycle Communication Solutions. If you're looking for an organization that provides expert answering services for healthcare, really an organization that understands healthcare and the unique answering service needs of healthcare, Stericycle can really help you out in this manner. They work with a lot of really large organizations with high standards, so it's a great company to work with if you're in need of those expert answering services. Plus, they also offer a suite of other patient engagement solutions, including things like automated texting, phone calls, and even online self-scheduling, which we talked about earlier in this episode, which is something patients really love. So if you want to learn more about these solutions and much more that they can offer, check them out at stericyclecommunications.com.
All right. That brings us to question number 3 topic that we're going to talk about. It's a pretty interesting one. It's talking about physician satisfaction, something that we don't really talk about a lot in healthcare. So, John, what's your take on this? Should we be measuring it? How should we be measuring it? What should we even bother with it?
Oh, physicians don't matter. No, I'm just kidding. No, are you kidding me? I mean, I read something today about how important the physician was to ensuring quality care was provided to patients. And I think we underestimate how important that the physicians are to so many aspects of healthcare. And, we certainly see a lot of physician burnout that's causing problems, not just personally for the physician, but also for patient care, also for an organization. If you have a bunch of burnt out physicians, you're not going to be a high performing organization. Forget about anything in value-based care. So I think it's an extremely important thing. And I think we're starting to see a lot more organizations wake up to this. And I think they're waking up to the fact that there's a lot more to physician satisfaction than just holding a yoga class or trying to provide them some sort of wellness solution survey to see how they're doing. There's just a lot more to it than that. And the other part that obviously for me as a health IT nerd and someone who's written about EHR for 13 years, for me it's really the physician EHR satisfaction. And there were a lot of great insights that came out of the Arch Collaborative event that I went to a couple of weeks ago with Class. So Class Research has put together the Arch Collaborative. They've done, I believe, 100,000 surveys of physicians, but also nurses, allied health professionals, to say how satisfied are you with your EHR? And now they're even going beyond that to burnout and some other things as well. But it was fascinating to hear some of the insights. And I think some people have construed it a little bit wrong. I think the EHR is causing burnout, but I think it's causing it across all types of EHR. Some are, I think, worse than others if you look at the data. But even the highest rated EHR has a lot of burnt out physicians and physicians that are really unhappy with that EHR, and they have some that are really happy. So, I think it indicated some really interesting. The EHR can burn them out, but there's things you can do to make it so the EHR is not burning the physician out nearly as much. Some of those things include proper training, enough training. So training was a key aspect that they measured, and the more training, the higher quality training they had, the more satisfied the physician. And then the second one that I think is really interesting is personalization. So how personalized have you made it? And have you done some personalization to make it easier for the physician to use? Which is interesting. Both of those are kind of require some training. And I think about all the doctors who said, I don't have time to train on it. It's like, well, you kind of just burnt yourself out by choosing not to go to the training or not commit enough time to it. So I think it was some fascinating insights as far as satisfaction.
Yeah, for me, physician satisfaction definitely should be something that organizations are measuring, and I think they are. I think for me, though, where I'm very keen and interested in is, is there sort of what would happen with HCAHPS? Can we do for physician satisfaction? Can we come up with a standard way to at least measure it? I know it probably won't be 100% accurate, but at least it's consistent.
You want to tie it to reimbursement like that too,
No,
or?
I'm not sure we want to go that far yet, but maybe one day someone will. But I'm just thinking.
I think every doctor screamed, no!
But I think even at least having the same metric across all organizations that you can at least do a benchmarking with to say, hey, is there some regional difference? Is there some size equivalency where it's a certain types of hospitals or certain specialties, and are neurosurgeons more burnt out than orthopedic surgeons, and at least be able to look at the data in that way to discover where there might be a hotspot. Where maybe there needs to be more interventions, because right now I think people are adopting solutions from other industries, but it's inconsistent. Some people adopt from hospitality, some people adopt from the the HR best practices. I think if there was some standard that it can at least be applied, where we can at least get a consistent foundation, then I think we can do some interesting comparisons and really look into like what is causing burnout, or what is causing some dissatisfaction. And for me, one of the biggest ones, I know you went down the technology angle, I'm thinking down the respect angle. I just think that physicians in a lot of cases feel that they're not treated with respect. That may be from their patients, it may be from fellow clinicians, it may be from administration, it may be from just in terms of their peers, right? Like just some of their peers just don't feel like they're being respected. So I think that that's an interesting one to look at, because I believe that has a bigger impact than a lot of the technology. The fact that you're just not felt that your time is being respected, or maybe that your voice is being heard. And I think those are fairly easy things to address, or at least can be addressed a lot quicker than implementing a new system.
Yeah, so the two great points. The first one is interesting. In the class data, they looked at it across size of organization, didn't see any correlation. They're like, okay, so the most funded ones, they should be better. Didn't see the correlation. A lot of the most satisfied, happiest users of EHR, the physicians, come from smaller organizations who have limited budgets and other things. So it was fascinating to see. And there wasn't, as I recall, I don't remember there being a regional difference either. there's dissatisfied ones everywhere and satisfied ones everywhere.
And says
Let's
my
put
word.
this positive too. Your comment though about respect is pretty fascinating. When I think about something I read today that said maybe we made a mistake in trying to trying to apply the Disney model to healthcare. And the
Mm,
Disney model is essentially kind of back of house. Don't let them see all of the crazy stuff that's happening to make this production amazing, right? So there's kind of a front of house and a back of house, and you never see the back of house at Disney. And so I've seen some healthcare organizations do that, where they hide the back of house. And someone made the assertion today that I read that said maybe that was a mistake, because by doing that, we hid all of the messy stuff. We hid all of the challenging stuff. I mean, if I'm in a waiting room and I'm waiting for an hour, it helps for me to see that the doctor's running around, seeing 6 other patients versus sitting up with his feet up with a coffee. And, like, I mean,
yeah.
that helps me like at least have some sympathy for them and understand, hey, they're racing as fast as they can to get to me. And maybe I should have a little more sympathy. Obviously, there's other ones, that I think apply to what you're saying. But I thought that was an interesting take as far as what we've done in our design, that maybe that wasn't a good thing.
Yeah, maybe we need those, maybe like the restaurants now where you can see right into the kitchen. We need something similar to that in the healthcare world, which actually is a nice segue into our last interesting stat to discuss, John. So this one comes to us from Kim Saxton, who tweeted this out during the Patient Experience Summit from Cleveland Clinic, and said, and what she said in a tweet was, employees will cut back 66% of their efforts if they feel they've been disrespected or experienced incivility in the workplace. And those who witness that incivility or witness that disrespect will have a 25% worse experience. So not only is the person who was the direct target affected, but those around it who witnessed it are also have a reduction in their effectiveness. So John, what do you think about this statistic?
Well, I mean, top of mind right now is we just announced the keynote for Expo.Health is Ivo Nelson and Dana Sellers, and they put out a book called Love-Based Cultures. And really at the core of that book is about effective leadership and kind of the balance of fear-based leadership versus love-based leadership. And that's what this tells me, that if you rule by fear, you may see some short-term gains, but you're also going to cut their effectiveness if they feel disrespected, if they think you're incivil in your conduct. And love is a much better approach in that direction. And so you might want to consider more of a love-based approach, like they're saying in their love-based culture book. So that was the first thing I think that came to mind. The second thing that came to mind really came from the Arch Collaborative event, and hearing all of these CIOs, CMIOs, physician leaders talking about the things they're doing that they are found successful. And if I were to sum it up into one word, it would be leadership. If you have effective leadership, you're going to do amazing things because you're going to have great governance, because the leader helps put that into place. If you have a strong leader, you can advocate for effective training and include that even in their requirement for employment. They gave a great example. They said, hey, you don't get a login to the EHR until you finish these 4 hours of training. And that takes a great leader to be able to say, we're going to do this. If you're not a great leader, if the other people walk all over you, then that causes problems with your organization. You're not able to implement these changes that will really improve satisfaction. So I'd say a lot of this goes back to leadership.
Yeah, I think definitely I agree with you. And the way I interpret this statistic, there's just two ways. One is sort of the overt incivility. There's the overt disrespect when it's between two people, between a leader and a subordinate, between a teammate and another peer. When you see that definitely, I think everyone would go, yeah, it's obvious that would have a detrimental impact on satisfaction and on workplace output. But I also think that, sort of to go back to what I said before around the disrespect that's hidden. If I'm a physician or a clinician and I feel that people are disrespecting my time, They're not respecting the value of what I'm bringing to the organization by, maybe it's because it's a harebrained policy that they've implemented, or that they've, asked me to track my time in a minutiae way, and me not understanding, well, the reason they need to do this is because of some reporting thing, not because they don't trust me, but I think it's because they don't trust me. Well, that to me is a disrespect. And of course, I'll tell my peers about it, and I'll tell my coworkers about it. And then that's just something that feeds on itself. So I think you have to be very careful, as you said, John. If you're a leader in a healthcare organization, you have to be very clear on why you're being asked we're asking your folks to do something, and you have to be very clear about what it is and where it's going downstream, so that people don't feel disrespected unnecessarily. I don't think you can do much about the whole fighting. That's a cultural thing, but I think you can do a lot of stuff related to the technology, where we just implement a policy and don't think about the impact of, well, did we actually just disrespect our physicians here? And and here you go, the statistics saying that 66% of them will just have will just really cut down their efforts.
So there's this really good post we just published from a new contributor to Healthcare IT Today named Nick, and he worked at a healthcare organization, became a consultant. He called it the silent sabotage. So go check it out at healthcareittoday.com. Read his story. He outlines this whole experience of the silent sabotage. So such a powerful idea. So check that out.
Yeah, and I think that's, what you say is very key. And, in healthcare, it's easy to hide, and it's easy to, we're so many moving parts where we can accidentally implement something that can do that, right? That can cause that silence, as you put it. I like that. And actually, that brings us to the end, John. So this is thank you to all of you who tuned in to this episode of Healthcare IT Today. Find out more details about our show, please check out the programs page on healthcarenowradio.com, and share your voice and engage with the community at healthcareittoday.com and on Twitter using the hashtag HITSM. I'm Colin Hahn with my friend and health IT collaborator John Lynn. Thanks for listening, and have a great week.